Dear friends, one of the common dilemmas which intensivists face in patients with septic shock with tachycardia is that should beta blockers be used for controlling the heart rate or not? In this video, I'm going to discuss the evidences about the use of beta blockers in patients with septic shock, when they should be used rightfully, and when it may be dangerous to use them. In our day-to-day life, we make choices. Some of them are good and some of them are bad. And if we are strong enough, we live with the consequences. But all is not bad about bad choices, because bad choices also sometimes make good memories. If you see globally, the beta blockers have one of the largest market share. If you see the CAGR, it has projected CAGR is 5.7%, 23 to 31. In its counterparts, other drugs have a CAGR of 1.5, 1.6, or at the most 2.1 or 2. So they are highly the popular drugs, and thanks to the increasing incidence of cardiovascular diseases associated with the surge in the geriatric population, along with the advancements in the drug delivery technologies, all of this has facilitated the use of beta blockers globally. And not just in the beta blockers, if you go by the Asia region wise, in the Asia Pacific region, also it has the high CAGR and the second largest market share. Now, the question is, what are the harms of tachycardia in septic shock? Of course, there is no two minds, there are no two thoughts that tachycardia in sepsis is harmful. It is harmful both because of the increased sympathetic activity with the resultant increase in the heart rate that reduces the diastolic filling time, so increases the oxygen consumption, etc. And a lot of studies have shown that beta blockers, when used, can be of benefit. Now, this is one study which was a large observational study, included nearly 5,000 patients to see the effect of beta blockers tachycardia and surviving following sepsis. And the results showed that tachycardia is associated with mortality and sepsis, and long-term treatment with beta blockers may have a protective role in both short and long-term survival of patients. Sorry. But then, is it always right to use beta blockers, or do we have other strategies too? There are some studies, however, which when tried to find the association between tachycardia and mortality in septic shock, they have also found that it is not that the heart rate alone is responsible. It is also associated with other factors. And those factors can influence the heart rate to a certain extent and modify its effects. Like, this study looked upon the effect of serum lactate levels and categorized the population based on the median lactate levels and tried to see when is tachycardia harmful, whether it is similarly harmful in low lactate and high lactate group, or the harm is different in the different groups. So here they found that the effect of tachycardia and hospital mortality differed according to the serum lactate level. When tachycardia was associated with high lactate levels, it had better outcomes. Now, this certainly raises one question, that tachycardia is also influenced by other factors. Similarly, another study looked into this ratio, that is the heart rate temperature ratio. And they found that elevated ratios, particularly above 2.22, are linked to high ICU mortality among critically ill septic patients. So since both the denominator and the numerator are important, if the heart rate increases and the temperature also increases, probably the patient's mortality may not be that high. On the contrary, if temperature is also low, patient is hypothermic, and the patient's heart rate increases or heart rate is even normal, the chances of mortality may be high. So these are certain studies which have also provoked us to think otherwise, that how we take the tachycardia and how we modify our treatment in patients having tachycardia and sepsis. Now, are beta blockers always useful to control heart rate in sepsis? Based upon the studies, based upon the physiological, our knowledge and physiology, we know that the distinction between the cause of tachycardia or cause of increase in heart rate, whether it is secondary, which is induced by a low stroke volume, or it is non-secondary, generated by excessive sympathetic response or an arrhythmic disorder, should be known. And that should be the main element to identify the patients who may benefit from beta blocker therapy. There is no universally accepted target for heart rate control, and the target has varied from studies to studies. Some have kept it at 84, some have kept it at more stricter control to 70, but there is evidence for individualized targets based on patient's condition and stage of the illness. So, in patients with early shock, a higher heart rate may be necessary to compensate for the reduced perfusion. And while in the later stage, patients may, or later stage means later stage of septic shock, the patients may actually benefit from lower heart rates to improve the perfusion. Therefore, trying to control the heart rate early may not be a good choice, and the beta blockers in those patients may induce hypotension and the negative chronotrophic effects, which can be unfavorable in these patients, while in the later stage, they are more likely to give the benefits. Now, there has been 3 studies which have tried to investigate the effect of beta blockers in sepsis. I'm coming from the second study. I will go to the first study was the Model study. I'm coming after that for the sake of clarity. The second study was this study, which was the Tony Whitehouse led investigation on Landilol and organ failure in patients with septic shock. So this study is called the Stress-L RCT. They tried to assess the efficacy and safety of Landiolol in patients with tachycardia and established septic shock requiring prolonged vasopressor support. So the question that was asked was that's continuously delivered beta blockade with Landolol for up to 14 days reduce the risk of organ failure as measured by the SOFA score among patients with tachycardia while they were being treated with norepinephrine for septic shock. And 126 patients were randomized into 2 groups of 63 each. The primary outcome was to see the mean SOFA score over the first 14 days after trial entry. And the range was given, and this was in 40 ICUs in National Health Service ICUs in the UK. And the findings were that these results do not support the use of Landiolol for managing patients with tachycardia and established septic shock because the SOFA score was no different. So they concluded that these results did not support. And even when they looked into the mortality over the 2 arms, this Landiolol doesn't work to reverse organ dysfunction, and it does not certainly improve the sepsis survival. So this was the Tony Whitehouse study, and it found that this study was stopped after recruiting 126 of the 340 patients because it was unlikely to demonstrate benefit and should recruitment have continued, and there was a signal of possible harm in this intervention group. Now, they had done this study because before them, Modeli et al. Had done one study in which they had used esmolol, and they tried to see the effect of heart rate control with esmolol on the hemodynamic and clinical outcomes in patients with septic shock. Now, this was also an open-label randomized phase 2 study in a university hospital between 2010 and 2012, involving patients in septic shock who had a heart rate of 95 or higher and requiring high dose of norepinephrine to maintain a map of more than 65 millimeter of mercuries. And they assessed 336 patients for eligibility and finally randomized 154 with 77 in each group, and 77 received esmolol as randomized and the other received the standard of care. And in this study, they had found considerable benefit in the esmolol group, both in terms of mortality and in the ICU length of stay, the 28-day stay, and the hospital mortality. So this study had given a hope or an optimism that open label use of esmolol was able to achieve reductions in the heart rate to target levels without any increase in the adverse outcomes with the standard treatment. So there is also a catch that whether there was no increase in the adverse outcomes, but there were better benefits. But this study had some major drawbacks because they used this heart rate threshold arbitrarily. It was a non-blinded study because they had to titrate esmolol, so it is not possible to blind. Even though the cardiac output was reported to be preserved in the group who received esmolol, the oxygen delivery decreased by 20%. So this fall in DO2, despite maintenance of the cardiac output, was not explained by the investigators. Then they found a very abnormally high mortality in the control group, which was to the extent of 80 to 90%, which also they could not explain. Enrollment was performed in high endemic areas of MDR, Klebsiella, and acidomatic pneumonia, and that might have led to secondary complications. They could not conclude to what extent non-cardiac mechanisms of esmolol, because esmolol has a lot of non-cardiac endocrine effects that can contribute to the observed improvement in mortality. So that was also not concluded or described. And they showed the study demonstrated unexpectedly large intergroup difference, which again points that it can be a chance finding. So these were the major drawbacks in the Morelli study, which led White House to conduct another study by using landiolol in place of esmolol. So, and one of the major drawbacks was that they excluded patients with severely impaired left heart function, which means that all those patients in our septic a large number of patients have already have impaired left heart function, cardiomyopathy, not cardiomyopathy, but various causes of heart failure. So now those patients need to be secluded. Beta blockers, the use of beta blockers cannot be generalized to the large number of patients. When we compare these two major studies, both the Morelli and the White House study, we find also that in the Morelli's group, they did advanced hemodynamic monitoring. And this advanced hemodynamic monitoring is something which may not be available everywhere in all places where beta blocker is used. Probably they will be able to pick up the changes in the heart following the use of beta blocker early. This was not done by the White House study. And accrued benefits can be realized only when the dose is carefully titrated with the availability of advanced hemodynamic monitoring, not otherwise. This conclusion automatically draws from this comparison. When we analyze this comparison between the two studies, this postulate comes forward. Then came the third study, which was done in 2024. This is called the Landicep study, which was published in Intensive Care Medicine. And in this study, again, they used landiolol with the control group, and they found that the primary endpoint had two components. The heart rate response, the target was limited, and they found that the target heart rate was achievable with landiolol. The vasopressor response was no different, and the outcomes were no different. So titrated IV landiolol increases the proportion of shock of patients with persistent tachycardia who have reduced and maintained heart rate without vasopressor increase after 24 hours. Without increase means without increase or without decrease both, and without differences in adverse effects and clinical outcomes. So this study also could not justify or could not support a treatment strategy of stringent heart rate reduction to less than 95 in an unselected septic shock population with persistent tachycardia. So it is very clear from these three studies which exists as of today, as of now, that before resorting to beta blockers, one has to consider preload optimization that might reduce the heart rate largely, temperature control, That will also help reduce the heart rate. Use of tachycardia sparing regimens of catecholamines like vasopressin, which can have less tachycardia and less arrhythmias. The use of steroids for shock reversal, and always a proper echocardiography to rule out a state of low cardiac output. And in many cases, if these approaches are able to stabilize the heart rate, then beta blockers will, of course, have very little role in the patients with septic shock. So, whatever studies have shown, if we try to propagate the use of beta blockers, then probably we might have to go for an approach that we have conclusion and we need evidence. So this is not possible because beta blockers in sepsis use is still shrouded with uncertainties. The first uncertainty is that esmolol has been found to be more beneficial than landiolol. Although the pharmacological properties of landiolol show superior selectivity, superior potency, and additional pharmacokinetic benefits when compared to esmolol. So, does that indicate? Because this may indicate that less beta 1 selectivity is actually beneficial. We don't know. We need more studies or standardized studies to come to a conclusion. Second, monitoring stroke volume would indicate any significant benefit or compromise from heart rate reduction, as the tachycardia can occur due to either sympathetic stimulation or compensatory to a sepsis-induced cardiomyopathy impaired cardiac function. So the use of ejection fraction as a marker, the left ventricular ejection fraction in this population has its own limitations because the afterload is reduced in sepsis because it is a distributing shock. When afterload is reduced, then LV ejection fraction does not become the reliable marker. So echocardiography measurements of diastolic dysfunction like septal relaxation or speckle trickling, which are afterload independent, should have been used. The studies have not used it so far. So only when the studies look into the echocardiographic findings based on such parameters like septal relaxation or speckle trickling that are afterload independent, a conclusion can be drawn with more certainty. And third, the potential correlation between efficacy of heart rate reduction and catecholamine usage or mortality is incomplete in these studies because the individual data is not available, and some of the 2 out of 3 studies have not addressed these issues. So these conclusions can become speculative. Both the negative and the positive conclusions can be speculative, leaving room for further exploration. So if Captain Haddock would have said that beta blockers are billions of bilious blue blistering barnacles in thundering typhoon of sepsis, then we have to be cautious. And our take-home message should read that systematic administration of beta blockers in tachycardiac patients, in septic shock in tachycardia is debatable. Echocardiography should be performed with parameters which are afterload independent to identify which patients can actually benefit from beta blockers. And when beta blockers are administered, the dose should be carefully titrated and patients should be closely monitored, preferably with advanced hemodynamic monitoring, because only then the best benefits can be accrued. So thank you.